Again, thank you for that comprehensive practice-changing study. This, I think, really is the issue, Tom Krivak. You said you believe in maintenance, and so do I. I think all of us do. I think that's the evolution of our field. But now the question is, what maintenance? And I get it, the cross-trial comparisons are inappropriate, but clinical decisions are appropriate and are made every day. And as we sort of look at this, Paula is provocative because of the active control. And, you know, I always say, if you can't beat something, compete against nothing. And many of these PARP inhibitor trials competed against nothing. Well, this here, there was a competition against a very active, in fact, now an FDA approved control. So as we look at this, and this is a key question, I don't know what you're going to say, but when you compare, and I get cross-trial comparisons are not appropriate, when you make clinical decisions, do you look at the hazard ratios of Paula and Prima, or, you know, PARP alone versus PARP Bev, or do you look at the medians? For example, Sharon says, well, you know, in the HRD non-BRCA group, which is this patient we just talked about, the median is 28 months. Or do you say, you know, you can't really do that? And certainly the elephant on the table is the sequential therapy. Maybe we need to look at, you know, Bev PARP, PARP Bev, or the combination, and we'll never have that information. So how do you sort of handicap this information that Sharon so articulately reviewed with us?
Yeah, I think that was great the way Sharon did it, and Tom and Katie and everybody. So how do you handicap it? The way I look at it is we have options. And so I like testing for HRD, and I completely, I think the fact that, I know we don't have any FDA labels, the fact that we have the HR proficient group that showed no benefit of dual therapy. To me, I kind of like when I see the HR proficient group, kind of want to go with single agent niraparib or single agent Avastin. In the HRD group, so the patients who have homologous recombination deficiency, I think that's a tough question. Do you go with both? Because you look at the absolute versus the hazard ratios. To me, they both work. Which one's going to work better? I don't think we'll ever get that trial. So if I have a patient who had really bad thrombocytopenia, she has issues with her platelets, I may be a little bit less hesitant to put her on niraparib and favor Avastin with olaparib. And I've heard some people say, just give olaparib alone. That's where you're going to get your maximum benefit instead of the olaparib Bev. But the trial was olaparib Bev. So I would do that. If somebody had a massive PE and doesn't want to be on bevacizumab, then I would use single agent niraparib. Where I kind of struggle in the hazard ratio absolute benefit is, you know, Katie had a very elegant study with Solo 1, and it was olaparib versus nothing. And you look at the hazard ratios, I always wonder what the hazard ratio would be in Paolo 1 if there was no active treatment. And should the BRCA mutated patients get olaparib with Bev? I think that's the struggle that I have. But across the board, you saw all three subsets or four subsets, what I just talked about. I'm going to give them something based on side effects, based on their molecular marker, or at least offer them, and they can make that decision. But that's how I kind of look at how three studies are all give us options, are all complementary. And really, when you look at all four studies, they solidify that we need to be using maintenance therapy for these patients.
Yeah, right. That's the key point. Yep. So remember, and Dr. Herzog, Tom Herzog, I got two Toms here. Tom Herzog, you talked about Prima very, very nicely, but it was a very high risk population. It was sort of the population that we feel the most comfortable using bevacizumab. There was a paper at the SGO, I think Grimm was the author, that sort of went through some of the subpopulations of Paula. Do you have that on your mind?
Yeah, I think it didn't really teach us a whole lot in terms of, you know, what we already knew, but it certainly reinforced. I mean, I guess I could throw it out to the panel for those of you that may not have read it. Who do you think did best? And it turned out that what they looked at was if you had primary cytoreduction versus interval cytoreduction, and if you had residual disease or you didn't have residual disease, and then what those hazard ratios were within the Palos subgroups. And so what they found was that if you had the primary cytoreduction, your hazard ratio was 0.52 versus 0.66. But if no residual disease, you got it all the way down to 0.47 And that was a big difference compared to 0.61. So it's a pretty big difference there, approximately 14% difference there. And then residual disease, there wasn't a difference. So it was really no residual and primary cytoreduction. Those patients did quite a bit better. But the treatment effect, other than residual disease, was across all subgroups.
Yep. So thank you for that. And again, thank you, Katie Moore, for leading the meeting and for getting these out in the public domain.